Everything said on this podcast is entirely for entertainment purposes only. This is satirical and should not be considered clinical advice. In any situation, please use your own clinical judgment, using your own knowledge, expertise, and research. Consult with your local eye department if you are unsure, and always act in the best interest of the patient. Do not listen to the things that we say and take it seriously.
Hey guys, welcome to episode 12 of the Glasses That Bill podcast.
He's
Thanks.
12.
Yeah, it's a fact that we were still doing this. God knows how. They're not being released yet, that's why we're still on this.
That's true.
But yeah, today we will be on the clock. Or on the fan and block.
Fan and clock.
Fan and clock. I know, but no one's going to get that. It's too bad. So,
Everybody will forget about that reference after first year uni. We'll get the
Yeah,
first year.
Opton's be looking at what's fan and block.
What's fan and block?
Yeah, I wouldn't have gotten that first year of uni. So what we're going to be doing today is we have 16 different eye conditions, mostly pathology, but a bit of other stuff as well. And we are going to be giving each other 60 seconds to using mainly yes or no answers to try and guess the diagnosis. This is purely an exercise of fun, I guess.
It's not clinical advice.
This is for entertainment purposes only.
But the reason I'm saying that is that this isn't how we do it in normal practice. This is purely just doing this colloquially. It's we'd have a lot more information available on hand. We'd have other people to ask. We'd have a lot more accessible
Physical
equipment.
examinations.
And also, patients never answer with a yes or no.
Is it best
For better or for
one
worse.
or two?
Yes.
Rounder.
That one.
That one's brighter. That one's brighter.
I
The edges are
once
better on that one, but the middle's better on that one.
had someone, I asked 1 or 2, and they went, yes.
You once that time, you lucky boy.
So many
I've
times.
had that once
No.
a day.
Do you know why I remembered it? Because it was in my stage 1, visit 3.
Fair enough. So this isn't realistic in any case or scenario.
Yep.
And I think in practice, I know some testing times are coming down, but hopefully you'll have more than 60 seconds to come up with a diagnosis and potentially management. Okay. Who's going first?
I'll go first. No, I'm not going first. I'm
That's
timing.
too late.
I'm timing.
No, it's alright. I got the timer up here.
I got timer here. No, and it needs the noise.
Mehdi.
It needs the ding, ding, ding.
No, he doesn't. Okay.
Okay, I'll pick it up.
Okay.
I'll pick it up for
You
you.
can pick it out, but don't look at it.
I'm looking at it. I'm looking at it for
Don't
you.
look at it.
No,
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 for
no.
you. Don't
Okay.
look at it. Thank you.
Damn it.
So,
All right.
60
Do
seconds.
we both get to
up.
look at this?
Yeah, of course. 5, 4, 3, 2, 1, go.
Is an anterior eye condition?
No.
Is it a posterior eye condition?
Yes.
Is it related to systemic issues?
No.
All right. Do you need to dilate this patient?
Yes.
PVD?
Yes. 15 seconds. Nice one. That was a bit
See, I'm
easier.
good.
Oh, you didn't get my help here. I know which one I see more.
PVD?
Okay. If a patient's coming with issues concerning a PVD, it's probably best case scenario that it's just
Yeah.
a PVD.
Yeah,
Otherwise, we have to detach or something else.
basically.
Okay.
Right. I'm free for the next 2 rounds. Are you going?
Yeah.
I'll take that off you. Thank you very much. So we have
All right. Okay. You need to show them. I'll put it on the screen. Okay.
Calm me down.
3, 2, 1,
go.
go.
Any visual symptoms?
Yes.
Yes.
Okay. Loss of vision?
Potentially.
Acute or chronic?
Chronic.
Cataract?
No.
Pain?
No.
No pain. Is this requiring a referral?
Yes.
Can do.
Okay. Systemic issues?
Yes.
Yes.
Posterior eye?
Yes.
Yes.
Mainly. But
So,
yes. Posterior eye.
emergency referral?
Can be.
15 seconds.
Retinal detachment?
No. When is red also not? It's carry
Oh.
on.
Sometimes we also.
And that's time.
That's
What
fine.
is it?
What do you think? Give a guess.
I just guessed 4 times.
Just give
Just keep
one.
guessing. We'll
final guess.
edit the
No,
timer.
just one guess.
The clock will keep moving.
One guess.
So it's a posterior chronic loss of vision. Okay.
And systemic that you also asked, but seem to
Oh,
forgot.
diabetic retinopathy.
There you go.
Oh, I diagnosed that. Oh,
The guy
my
goes,
God.
"Is it emergency?" I'm like, "It can be," and he's like, "Retinal detachment."
Oh my God.
Can be.
See, so
Quick,
if you
pick another one.
if you want to get refracted, give
Go
to
on, do
him.
you want to go
If you
again?
have eye problems,
Do you
don't.
want to try again?
Okay. All right. I'll count you down. 5.
Wait. Actually, yeah.
I've got a timer.
3,
5,
2,
2,
1, go.
go.
Reduced vision,
Sometimes.
Yes.
pain,
Yes.
Yes.
halos around light.
Yes.
Yes.
Okay, I'm going to pause it. Okay.
Good job.
Yeah, this was one of my Oscar stations.
So that's why I got it in 15 seconds.
It was just, I mean, sudden painful loss of vision. It's.
Your first thought is angle closure, is it?
I mean, it wasn't my. I was thinking.
That's usually my last thought in terms of emergency. Because when I get loss of vision and pain, I always think ulcer. It's more common. And then I'm just like, right, just do pressures just to make sure.
In Edinburgh, I saw so many uveitis cases. That became my
I've only
idea.
seen one.
I saw I would see like 2 a month. I don't know what's
Really?
there. Honestly, I saw so
Something
many
in the
uveitis
water.
cases. Absolutely. And even when I went to the
Highlands water, really?
hospital placement, most of them were uveitis.
Mad.
At least 60% were uveitis. So that became my go-to. But yeah, the halos around light.
The thing is, I diagnosed uveitis through process of elimination.
Really?
Yeah, so I get stuck between angle closure and uveitis.
So you put them on slit lamp,
And then-
check Van Herrick's, and then you move into the anterior chamber and you check for.
Yeah.
conical
So,
beam.
but sometimes I've seen like uveitis where I do conical beam and I don't see any flare.
Is that just because you put it on ×6 mag?
Maybe.
It's
But
I've not seen uveitis without flare.
I usually see it.
Well, without cells of flare.
But like when I don't see flare, and then let's do pressures. And look at the pressure. Like, okay, maybe.
So that's your differential diagnosis. You know,
Yeah, between these two.
You'd look for. You'd go Van X first, and then look for cells of flare, and then.
As in purely on the basis of anterior to posterior.
Yeah. Of
I
course.
mean, I mean, to be honest, in practice, you always get the contact tonometry before you come in anyway.
You're getting pressures. So
You're getting pressures
But
regardless.
assuming you don't. Assuming they couldn't do it because it's one of those cases where the pretest was unable to get the pressures.
Like one of our colleagues, they had to do eye care because the patient was on a wheelchair. They thought it was uveitis, couldn't get them on a slit lamp, so couldn't check anything.
Ooh.
So he got the eye care, and the pressures were like 70.
There you go.
It's like, oh, I know what that is.
Photophobia is a big hallmark of uveitis.
Yeah.
And
But that's also an angle closure.
Yeah.
No,
not
really.
really
Yeah.
the same.
Not really. What are the 5 main
For angle closure,
angle closure?
halos around lights, nausea, pain, redness, photophobia, and blurry vision.
It's not photophobia.
Photophobia is one of them.
Sensitivity to lights. It's
That's
different to photophobia.
it's clinically
The
photophobia.
differential for uveitis is you put them on the slit lamp. You go to the
Uveitis are walking in with sunglasses.
You put them on the slit lamp.
Yeah.
You put them on the slit lamp. You put it on.
The severity of photophobia is different.
You put it on the full beam.
Yeah.
You put it on the wide beam,
Yeah.
the tall beam.
Yeah.
You turn the brightness off, and then you turn the brightness to full. And if the head hits the ceiling, then it's uveitis.
That's a very crude one.
Don't. This is not clinical advice.
I was not listening for the first half, and they said you turn up max and see how they react.
You just open the width of the beam, and if they immediately recoil and jump backwards, then you know that's photophobia. If you do that and they sit through it, maybe not uveitis.
If they're walking in with sunglasses on and they say that bright lights hurt, they take off sunglasses and got red eyes, they've got uveitis. Not clinical advice. But yeah. Okay. Redemption, because I've completely forgot systemic issues. Sure.
Oh, what, uveitis?
No.
Oh,
It's your
it's
turn.
go on. I was going to... It's arthritis.
Stop
There was a kid I saw
looking.
juvenile chronic arthritis, and he was under the slit lamp clinic every 3 months to make sure he wasn't developing uveitis.
Mad.
Do you want to hurry up?
And I'm trying to randomize it.
If you get myopia,
Strange, but
all right.
Okay.
5, 4,
5, 4,
3, 2, 1, go.
anterior eye problem.
Yes.
Yes.
He's buggered.
Contact lens barrier, or
uh,
associated with contact lens
irrelevant.
barrier. Is
Should have
it
said yeah.
raised IOP?
No.
Okay. Is it a cataract?
Unless,
Yeah, he's got
Is it
it.
So wait. Anterior eye problem. IOP is normal. Oh, cataract.
No, I'm just working my way back.
Nobody guessing. Let's ask him more questions. Take another one.
Okay.
Dude, yeah, that's not real.
But the thing is, the IOP one, pupil block.
Yeah, but that's you're talking about the actual cataract, so not nuclear sclerotic cataract. Not everyone's going to have IOP. It's in like a really
No,
rare case.
A very rare case, but not.
The
It's
IOP
the
would
same
be-
as this guy dilating
IOP
myopia patient.
No. IOP would be raised pre-cataract to post-operative. Post-op, that IOPs will be reduced
Yes.
Yeah.
Yeah, but it's
because
not,
there's less volume
but
of
when we
lens.
say raised, you mean abnormally raised. Although I could have said yeah and thrown you off.
Contact lens barrier, yes.
Yeah.
Raised IOP, yes. What is this? What is this scenario?
I can close uveitis with a corneal ulcer.
Everything's wrong with your eyes.
Okay. 5,
Right,
4, 3, 2, 1.
go.
Reduced vision,
Yes, it can be.
painful,
No.
red eye,
No.
anterior problem,
No.
posterior problem,
Yes.
retinal
Yes.
Okay.
problem, retinal problem,
No.
uh,
No, it's not.
is it an optic nerve head problem?
Yes.
Is the IOP raised?
Yes.
Are they? Oh, how many seconds have I got left?
You got 30 seconds. He knows what it is.
Keep
They
going.
have a family history of glaucoma.
Yes.
Yes, they do.
What's the Vanerics?
What?
Okay.
What? No. Three.
Is it primary open angle glaucoma?
Yeah. Wow.
I was going to ask if they're Afro-Caribbean over 40 female with large discs
You
and
should have asked about the
Like
24-2
field
results.
defects.
Should have asked for the 24-2 results.
He's a 2, easy. Unless it's myopia or retinal. Or diabetic retinopathy.
Oh, this is a good one actually.
3, 2, 1.
Okay. Visual complaint.
Yes,
All right. VAs.
reduced.
6,
Okay.
9.
All right.
Reduced.
Acute.
No.
All right. Corneal pain.
No.
Okay. What does the cornea look like?
Yes or no question?
Clear.
Yes.
All right. Is the cornea clear?
Yes.
Is the lens clear?
No.
Cataract.
No.
No.
Oh, okay. All right. Is the fundus healthy?
Probably.
Can't tell.
That wasn't a yes or no answer.
What? And it's not acute. Is it systemic?
No.
No.
He's actually gonna.
He's going to hit himself.
How
You
did,
got 5 seconds.
how did you miss that one?
Come on, buddy.
You're
But it's not acute.
Done.
No. The part where you said, is it lens? And we said yes.
And I
It's
said
lens, but
cataract.
it's not cataract.
What else could happen on the lens?
PCL.
Yeah. Nothing.
5, 4,
Wait. I'm still looking at
2.
PCO.
1.
Right. Reduced vision.
Yes.
Pain.
No.
Redness.
No.
Is it a retinal problem?
Yes.
Yes.
Is it systemically linked?
No. No.
No. Is there hemorrhaging?
Can be.
Yeah, can be.
Is it Wait,
That's
how
question.
reduced are the visions? Is it beyond 6'9"?
6:30.
Yeah,
And there can be hemorrhages.
it can be.
Is it diabetic retinopathy?
No.
No. 20 seconds.
Is it a vein occlusion?
No.
No.
And it's a posterior eye problem. It's not an anterior problem.
Yeah.
Correct. 10.
You
Well,
get
that's good.
hit
What's
yourself.
hemorrhages? Is it wet AMD?
Yeah.
Very good.
Woo.
Yeah, I mean,
Forgot that was there.
I
covered a
forgot
lot
that was
of
there.
That's good.
I forgot about AMD.
I'm seeing something in the back of the eye. I don't know what it is.
Would it be hemorrhages or would it really
It can.
You can,
get
because
hemorrhages, absolutely.
it compromised the blood retinal barrier.
Yeah, if there's neovascularization and
No, there absolutely can be
if there,
hemorrhages in wet
as
AMD,
in generally.
I mean,
as in
don't blame us for that being the
I
main
mean,
point of
no,
your
but that-
diagnosis.
your cheeky bit of drusen. That's not. That's what we talk about. When we
Wet
say,
AMD, a
Oh,
cheeky
no.
bit of drusen.
Okay.
Don't leave it in there. It just
Or are we taking them out now?
yeah, we're taking that just so we don't have repeats.
All right.
Okay.
5, 4, 3,
Okay.
2, 1. Reduced vision.
Yes. No. Yes.
Acute.
No.
Redness.
No.
Pain.
No.
High pressures.
No.
Is there
I don't know.
systemic issues?
No.
Retinal, yes.
No.
No.
Okay. Is
Go for it. Off the right.
does this require referral?
No.
Hospital visits?
No.
Mm-mm.
Can it be corrected with glasses?
Yes.
Yes.
Is it presbyopia?
Yeah.
You got there in the end.
Should have asked if it
What
is
was
a
it?
lens issue.
Yes. It is a lens issue.
3, 2, 1, go.
Is it? Does it affect vision?
Yes.
All right. Is it acute?
Yes.
Yeah. Okay.
Yes.
Yeah, no.
Is
it's
it painful?
No.
Redness?
No.
Irritable?
No.
No.
Painful? Did I say?
No.
No. Okay. Is it anterior eye?
No.
Okay. Is it systemically linked?
Yes.
It can be.
It can
On
be
every
systemic.
situation.
All right. Okay. Is it age related?
No.
No.
All right. So does it affect the retina?
Yes.
Yes.
Okay. And it is acute.
Yes.
Do you need to dilate?
No.
No. Is it a referral?
Yes.
Yeah.
I mean, should we be answering these questions? Go on.
Is it emergency?
No.
No.
Routine?
No.
Urgent?
5 seconds.
Macular issue?
Yeah.
Yeah. From the present macula. And
CRO.
time's up.
Yeah.
Oh.
Oh, in the nick of time.
Yeah.
We'll have to watch that one on VAR too.
Well, sorry for that. But yeah. Was there any point where you were thinking of something else?
Yeah, I was thinking wrist attachment. Primary cataract. I was thinking wet AMD, but that had already been gone, and then diabetic retinopathy.
Oh, stop playing the game.
Yeah, I know. So why would this not? How would you differentiate this from diabetic ret?
Well, you'd see a lot of you wouldn't see your standard diabetic retinopathy signs, so like your looping, beading.
So just looking at the retina, not seeing a continental spot, seeing just a widespread.
Just widespread flame hemorrhages, and they usually have a
They'll
similar
follow
pattern
the arcades
to the
in
arcades.
that one, whereas in diabetic it's meant to
Exactly.
be more in the
Yeah.
macula
Absolutely.
or scattered.
But also, like in diabetic retinopathy, with the something like CRVO. where
Also, you said it's acute.
Acute.
no, but I think
You can't get acute diabetic retinopathy because diabetic retinopathy
Yeah,
is
true.
not an acute condition.
yeah, no, the way it's written, you're right.
It's a prolonged.
And what? How would you differentiate that from wet AMD? Because also that's another thing you were thinking about.
Because
Systemic links.
yeah, because I knew where MD wasn't in there.
He's just
But-
no. Say in practice, how would you differentiate
in
this
practice,
from AMD?
you would see flame hemorrhages everywhere.
Just by looking at the.
Yeah.
Okay. Valid. And So obviously you knew it was a CRVO because we didn't have all the occlusions in the pool.
Yeah.
Apart from, what's the difference?
What's the difference?
CRVO, BRVO, just for education.
CRVO is leaky veins.
Okay, but CRVO central, everything's hemorrhaging. Where BRVO is only
It's a specific vein in the retina
Exactly.
is leaking basically.
specific like top bottom
Yeah.
patch of it, and
It's basically what. So it's a BRVO is exactly the same in terms of appearance of a CRVO, but it's localized in a specific area.
in a branch.
Yeah.
Sort of and the artery occlusions.
White. It's pale.
Lack of blood.
Yeah.
Lack of blood. So
Looks
it's less
pasty,
redness,
yeah.
or the central artery cherry red spot.
Yeah.
One of my lecturers had seen a patient with central artery occlusion,
Yeah.
and you know, with one of those, like, pretty much if you're seeing it in practice, it's already pretty much too late.
Yeah.
And they need to be, getting as much carbon dioxide in the system, and on the way to the
Yeah.
maybe not as much, but on the way to the hospital ASAP.
Yeah.
He saw a patient be successfully treated for CRVO.
Nice.
Central retinal artery occlusion, and reason being, he was already in the operating theatre for a separate ocular issue. That's the only way, because he was already in the
So
hospital.
he saw it as
he
they
was
were
having
doing
his cataract surgery done.
He wasn't having his first or second cataract surgery done, but he was
And they found a
somewhat
second.
systemic. So some other, he was having his diagnose. Some other systemic issue at the back of the eye. Some,
Peel or something.
I think it was more cardiovascular related, but
Given the reveal.
yeah, exactly. But the sad thing is, two
Yeah.
weeks later, he had another CRO, and he had it at home and he lost his vision. So all that, like, it obviously wasn't futile. He got 2 extra weeks of vision, but it was such a shame that after that stroke of luck, well, I don't know if you call it luck, but to be in the situation where you can't get treated.
And your time starts in. And go.
Visual acuity better or worse than 612?
Worse.
Worse. Okay.
In later stages.
Pain?
No.
Later stages, interesting.
Why did you give that away?
Is it a retinal issue?
Yes.
Yes.
Okay. Is it chronic?
Yes.
Yes.
Does it cause distortion?
No.
No.
No. Okay. Eyepiece normal?
Yes.
Cornea clear?
Yeah.
Lens clear?
Yeah.
That's good to know.
Secondary cataract.
Optic nerve healthy?
Yeah.
Yeah, I think so.
Is this linked with smoking?
No.
Okay. Is it linked with UV damage?
No.
Okay. Is
What damage?
UV?
Oh, okay.
No.
I think it's solar maculopathy.
Okay. Is this got a familiar link?
Yes.
Okay. Does it primarily affect the visual field?
Yes.
Is it retinitis pigmentosa?
This is.
Yes. After a minute and 15.
I don't have to
I
stop.
forgot. I
What?
forgot when you
I
said.
thought you were keeping time.
No,
Yeah, it's at 30. I forgot. No, it's okay.
This is why I said we need a clock.
we didn't need a clock. I thought you'd have the beauty thing as well.
No.
I thought for the beginning, I thought it was open and shut, dry AMD. But then it's like, okay, it's not linked with smoking. It's not linked with
UV.
Yeah, UV. I said, okay, so it's not dry AMD.
I thought you said UV wasn't real.
Yeah, UV is not clinically known to be affecting
Yep,
AMD
clinically
apparently.
known to be. You said that to me.
Because I told him.
Yeah, you told me that.
It's I read. I was doing the WordPeg Mex course, and recent study. This was like last year, so
No,
they
you
might have
showed-
done a
no,
study
you
that
showed me
proves
Instagram
otherwise.
post for this.
That's something.
No, that was 2020 rule.
Oh right, yes.
Yeah, no, but UV has no like actual effect on it.
Really.
Yeah.
Then how do you prove the fact that the patient who spent a lot of time in the sun had early?
Causation, correlation.
Whose turn is it? Shreve's turn or my turn?
It's your turn. No,
Mine?
no, it's your turn.
It's Shreve's turn.
I dropped the
Well,
gun.
I'll put the timer on this time.
Thank you.
3, 2, 1, go.
Is it refractive?
No.
Is there reduced vision?
Yes.
Is it retinal?
No.
Lens?
No.
Corneal?
Yes.
Is it a contact lens associated?
Yes.
Is there staining on? Is there...
Yes.
Okay. Is there reduced vision?
Yeah.
Is there photophobia?
Yeah.
It's not keratoconus, is it?
No.
Okay. Is it a corneal ulcer?
Yes, it is.
Nailed it. Nailed it. Open the shot when you find out it was all the cornea.
Legit.
What? So.
Ask me questions. I've referred
This
to
is
them.
not his area of
The
expertise.
patient has been referred. They're on the way to the hospital. They're going to be treated. Okay.
Have you ever seen band keratopathy?
I think so.
No, I don't think you have.
I've only heard of that.
I've seen it on my notes 3 times.
Have you seen Vortex?
What, from the army?
I'm the older one.
I love how you both said that.
No. you guys are on it.
Like I thought I had a bit of obscure knowledge, but apparently it's
Settle
common.
down, buddy.
Have you seen it? That's the
Of
question.
course not.
Have you
Have
seen
you?
it? I don't know. I feel like Shrey was someone that would have seen it.
I think I've seen a patient
I told you.
who was on it, but I don't think he had the keratopathy.
No.
I think he was screened for it. He was screened for it.
What do you look for that?
It was like a. Is that vortex keratopathy? So they have like a weird,
I think so. Something
like
that.
a vortex shape.
Okay, ready, you're up.
No, I'm up, down, spinning right round.
Are you 6 as well? Okay. Right, your time starts now.
All right.
It was me. You have to go.
Is it VA affected?
Go.
Yes.
VA affected.
Yes.
What
Is
was
it
it?
retinal,
Yes.
Yes.
macular,
Yes.
systemically induced,
No.
systemically related,
No.
emergency,
No.
routine, referral,
No.
monitor once a year.
Not a blanket.
Is it acute?
No.
No.
Is it a dry macular degeneration?
Yes.
No, it's DAMD.
Damned.
It's it's a pretty. What do you discuss, or how do you discuss smoking? Do you bring it up if you can smell?
I just ask.
strong stenches. Yeah.
You just
Okay.
like,
If
do
you
you
can-
Did you blanket ask everybody in the history and symptoms?
You should do.
I don't think it's NHS required, but
It's not NHS required, but it is a good question to ask as a
Absolutely.
blanket question.
it's so uncommon now. I don't.
Yeah,
I like.
and the thing is, when you can smell it on them, you kind of know they smoke it. So
So that's when I bring it up.
Does vaping count?
The jury's out on that one.
does
You like-
vaping have? I don't know if vaping has an effect. Does it? Does it have the same?
I don't
Is
think
it like? Cause is it the nicotine that's causing the problem?
no.
Because I don't think vaping has a similar.
Tar.
Do you do shisha?
It's
When was
if-
the last
if
time
the-
you put your head over a bucket of Vicks? Hot water.
yeah, it's
If you see
I
the
was
Muslim
mentioning that.
name, do you do shisha?
I was mentioned that ask a patient, do you smoke? It's and I just say that I'm sure you don't need me to go over all the health risks of smoking on set
Yeah.
now, because nobody doesn't know what health risks of smoking.
It's literally written on the packet.
You can't avoid it. It's and some people trying to work in it, some people aren't, but that's their prerogative.
Yeah.
I had a patient once who came in. Was type 2 diabetic. He was like mid-30s. Slightly overweight. Obviously had health problems. And when I was asking about diabetes, I said, "Is it type 2 diabetes or type 1 diabetes?" And he said, "It's the one that you give yourself. It's the one that's my fault." And I said, "No, don't say that. There's obviously predisposition factors and there's a lot of He goes, "No.
He's owning up to it.
I had a really good 10 years. I enjoyed myself, and now I'm diabetic." I wasn't sure what to say to that.
Any tips?
He said, "No, I really enjoyed myself for 10 years, and now I'm diabetic." But it was a great 10 years.
Yeah, smokers know that's not good for them.
That's
They don't need another.
Yeah, I think the only thing that you'd say to them is what you may not know is that there are some links with the eye and the eye health that could be
To be honest, if they
exacerbated by smoking.
they know that it's likely going to cause them an early death. They know they're likely going to have an increased risk of lung cancer and heart attacks and all of that.
Of course. But
You
what I'll
just-
say to them is what you don't know is that at the back of the eye there's some wear and tear. There's some signs of it here, which is not
Which is
normal,
normal.
to see. It's not normal to see.
So
and
this is a
therefore-
patient that smokes and has AMD.
So I'll say to them that you've got AMD, and then I'll say one of the risk factors for this is smoking, and this can exacerbate it and make it worse. So obviously, as a smoker, this puts you more at risk of having, assuming it's dry AMD, I'll explain what the risk of wet AMD is and what the signs and symptoms are and what to do if it occurs. And I'll say to them, smoking increases your risk of having wet AMD, so therefore,
I would go into the
So
approach of
try to-
saying
try to
having
stop-
dry AMD increases the risk of having wet AMD, but I would be going to saying if to slow down its progression, quitting smoking is a very effective way to do that.
I've never had a patient not respond well, but I've never had a patient consider they normally just accept that this is another issue of smoking. They don't think. that,
Yeah, but
okay,
you have to give that advice.
Of course, no, but yeah. of course, they
Regardless
don't-
of whether they're gonna take it, you have
No,
to
you
be
have
like,
to tell them this is due to smoking. But I'm just talking about the response. I'm not talking about the advice.
Yeah,
The
yeah,
advice
okay.
is
Do you
just-
not follow that on with, so if you were to stop smoking or reduce your smoking, that would improve
Oh,
your...
absolutely, no, absolutely. But I'm just saying that
That's what it is, really.
the reception I get
Oh yeah, of course.
is it's just a case of because obviously a patient has dry
oh well, I've
AMD.
done it for 60 years.
Exactly.
Yeah.
A patient with dry AMD, they're likely a lot older.
Yeah.
And they've been smoking is probably a habit. They might have tried a couple of times to stop it. But at this point, they're just like, just another
It's a
thing to add
habit
to the
now,
list. Yeah.
Left.
Two.
Okay.
Okay.
3, 2, 1, go.
Okay. Is their vision reduced?
Yes.
Yes.
Okay.
Is it painful?
No.
No.
Okay. Is this emergency referral?
Yes.
Okay. Is there redness?
No.
Okay. Is the IOPs normal?
Yeah.
Yeah.
Could they be reduced?
Reduced. Yeah.
Are they
He knows
getting
what it is.
flashing lights and filters?
Yeah.
No, they're actually
No
with
flashes,
with
just
a-
floaters.
With a curtain and everything.
No flashes, just floaters.
Are they highly myopic?
No, they're not.
Yes, they are.
No, they're not.
Yes, they are.
They could be.
They could be.
Have they had recent head trauma?
They could have.
Yes. They're a high myopic.
They're walking you fresh from a car
boxers.
crash.
Fair enough. Fair
Oh,
enough.
you got 2 seconds.
Roll attention. That was close. Okay.
Nice. Good job.
Yeah.
That was tricky, man.
No,
That's so tricky. Did you see it?
Did you see it?
No. It's killing the ball, mate. Come on. You've been facing me for the last half an hour. Just do it. So-
Pick the other one.
Okay, fine. I'll do it.
Right.
You
That
need
was,
to look at
that
it.
was a subconjunctival hemorrhage.
Okay, so no, with the okay.
Yeah. It's got
That
to be.
escapes this one. That was one you wouldn't have beaten.
No, Matthew started silent.
Okay.
What is that one? I didn't see what he's got to guess.
You don't need
Can't
to-
answer
Oh,
questions.
it's on the list. Crap.
Okay. I didn't know. I don't know what was on the list.
3, 2, 1, go.
Is it refractive?
No.
No,
Why you-
no,
Is it a retinal problem?
No.
Anterior eye problem?
Yes.
Yes.
Is it corneal?
No.
Lens?
No.
Anterior chamber?
Yes.
Well, yes.
Anterior chamber? Is there redness?
Yeah.
Yes.
Is there pain?
Yeah.
Is there photophobia?
Yeah.
Yes.
Are they coming in wearing sunglasses?
Yeah.
Do they have rheumatoid arthritis or
Yeah.
juvenile chronic?
No, not this
arthritis?
one.
Not this one. Okay, so they're different.
It's not that.
Is it an emergency referral?
Yeah.
Have they got a mid-dilated pupil or a constricted pupil? Is that an iso?
Yes, the posterior synapse. Yes.
Is it anterior uveitis?
It
It is.
is. It is
Yes.
anterior
Wow,
uveitis.
nice.
Fantastic.
Is it just uveitis? I
It's
can't remember what you
uveitis.
wrote. Yeah.
It's uveitis.
Yeah.
That should be what you're basing on.
Yeah.
Yeah, send them away to get some steroids.
Yes. Dilate them in the meantime.
Why?
Why?
Oh no, wait.
are
Constrict them?
you-
You dilate everyone.
Are you,
No, no, no.
Legit?
No, no,
Yeah.
no.
Do you mean in terms of symptomatic relief?
Yeah.
In
Is it
theory.
dilation or
You mean
constriction?
No,
cycling?
if you try,
You cycle them,
why are
don't
you
you?
trying to break up the posterior synapse? Just send.
Out you get. Right, I know what's wrong with you.
No.
Out you get.
You give them some.
I
wait, hang
fix
on.
you.
Wait, hang on. It's been a long day. You dilate, don't you?
You need to freeze the
you could to
uveal.
try and attempt to
To-
break the posterior sinecate
Yeah.
attachments onto the lens. You could try and dilate.
Just
You
to
know.
relieve the
It's,
pain.
it's no, it's for
No, it's-
symptomatic relief.
Okay.
It's to freeze the accommodation. It's to stop the muscles from moving because it's inflamed, because it's the uveal layer. So by dilating them, you're
Paralyzing the.
paralyzing
So,
that
okay,
part for 6.
buzzing.
Yeah, you're paralyzing that part for 6 hours. Atropine.
Yeah, because I saw a patient once who came in
Yeah,
for an
it's
uveitis
the atropine
after
that does that, I
having
guess.
uveitis the
You could
past
do
week.
cycle. You could put
And-
So
anything
yeah,
to-
Yeah,
atropine,
anything to
yeah.
dilate
Yeah,
or to cause some
But
psychology.
from my knowledge, that you don't give them that to
Oh, you don't
break it. You give it for symptomatic relief.
Okay. I
That's from my knowledge. I don't know
From-
how clinically accurate or correct it is, but I
From my
still
knowledge.
wouldn't dilate them. I just send them off.
Oh, well, if the patient's in front of you in agonizing pain and you have the ability to relieve that pain in the 6 hours it's going to take for them to be seen by a consultant, you're going to drop.
6 hours?
Oh, well, let's assume that
Jeez.
the patient's going to go home and
No, usually they'd be seen sooner than that
actually probably
because you're referring them.
because they're trying to dilate, but you can just speed up the process. Call your local eye department and ask the consultant what he'd like you to do.
It's not the best way to.
Yeah,
So,
just
yeah.
say, "Are you busy?
You busy now?
What have you had your lunch yet?" And they'll say, "It's 4 o'clock on a Friday, mate. Just send them up, but chuck in some."
It's the on-call
Should pick a
ophthalmologist.
knife.
Are you home or at your work?
The or maybe guess the last one.
Is it subconjunctival hemorrhage?
You're good. Oh, you're good.
No, it's a
You're good.
Did they walk in?
It's a
Oh, right. So it's subconjunctival hemorrhage. Everyone knows that.
Yes.
That's the
Sheffield Children's
commonly used
Hospital.
acronym, isn't it?
Yeah. Sheffield Children's Hospital.
Who's
Subconjunctive.
writing?
Subconjunctive is what you write.
Yeah. Subconjunctive. Yeah, that's literally what I write.
Subconjunctive.
No, I write out the full thing in my notes, but
Why'd you write the full thing?
because it's
Which
contracted.
non-competent optometrist does not know what a
The same ones that
subconjunctive
doesn't
is?
know what SCH is.
No.
You two.
Well, in case of you mean the subcon.
Oh, there's Sheffield Children's Hospital in there.
I can't think.
Yeah, I
of
don't know. I
I
know what
can't think of
subconjunctival-
another word that starts with CONJ apart from conjunctiva. Congenital.
What eye
With a
condition
G.
is SCH? What else could it be?
No. In my notes, SCH means other things.
What's it mean?
Conjecture.
You got one of the letters.
Conjunction, in conjunction with, yeah.
Yeah.
Sheffield Children's Hospital.
That we should.
Oh.
When I write my letters, I
Yeah.
write letters from SCH.
Also, the
Valid,
email is
valid.
SEH as well.
SCN, is it? Is SCH or SCN?
SCN is Special Educational Needs. SCH is Sheffield Children's Hospital.
So yeah, hope you did enjoy that.
I didn't enjoy
No one's
this.
watching this.
Nobody enjoyed or watched this. But yeah, what were you saying? Thanks for joining us. Thanks for joining us. We'll see you next week, hopefully.
Hopefully, maybe if
Maybe,
we're live.
maybe not.
Yeah, probably. We might not be next week.